Welcome again, all of you, for the National Neonatal Forum Karnataka chapter web series. So today we have got really a good topic which we face commonly in our neonatal practice. That is the abnormalities related to the low platelet, or the issues what we face when we are dealing with low platelet thrombocytopenia and a bleeding neonate. When we see, when you notice blood in stool or blood in skin or skin bleed. So today we're going to talk and discuss on all this. So we have two wonderful speakers, Dr. Archana. She's a consultant neonatologist, chief consultant neonatologist at St. Philomena's Hospital. And she's been our ex-secretary's NNF Karnataka chapter. And she's known for her wonderful talk. We welcome you for the session. And her session will be followed by Dr. Deepak, who is a consultant neonatologist at Deepak? Apollo Cradle. So he'll be talking on approach to a neonatal, a bleeding neonate. So let us start the session. Today's session will be moderated by Dr. Girija, who has already joined. So all the questions, everything you can post once the end of the session, and we'll take up for discussion at the end of once the talk is done. Both the talks are done. Over to you, Dr. Archana.
Thank you very much.
1 second, I'll just stop sharing. Yeah.
Oh, I'm sorry. Yeah. Okay. Just hold on. I'm just fixing my screen.
Yeah.
A lot of pop-ups that I don't know how to. Why is a waiting room thing coming in mine?
No. My screen. You're a co-host. That's why I'll take care of that. Don't worry about that.
Okay.
Just cancel that.
I got it. Okay. All right. Thank you to NNF Karnataka and the team behind this the webinar series for giving me an opportunity to put my makeup on. It's been quite a few days since I did this. Today I'll be talking about neonatal thrombocytopenia. I'm hoping to finish it in 30 minutes. This is a common problem, like Dr. Prashant said. We face it in our day-to-day life. We see some cases where there's incidental finding of thrombocytopenia. Sometimes it's expected. Many times it resolves by itself, and that's when we relieve. But sometimes it persists or becomes severe, and that's when we worry about. But till it resolves, we can't sleep in peace, can we? So the objectives for today's talk would be a diagnostic approach to a baby with thrombocytopenia. I'll be covering some common conditions causing thrombocytopenia, indications for platelet transfusion, something about fetal thrombocytopenia, and some of the controversies that are now there. Now, these are the common situations that we find in the NICU. Like you see a preterm baby who's well but has a platelet count that is low at 24 hours, or a baby who's IUGR and has thrombocytopenia, or a baby who's been doing well and on day of life number 5 suddenly has thrombocytopenia. We have also come across term babies with perinatal depression or asphyxia and has thrombocytopenia later. We have also come across babies who are term and well and present with seizures. They could also present with bleeding, major bleeding like GI bleed or intracranial bleed. This we find in our day-to-day life. But what are the indications that we check platelet count in babies? Often we check it in all the sick babies when we're suspecting sepsis, asphyxia, or NEC. We also do platelet count when there's a sibling history of immune-mediated thrombocytopenia, or when there are risk factors like placental insufficiency, IUGR, torch infections, or dysmorphic features. We do platelet counts when there is a bleeding neonate with a GI bleed or petechiae or intracranial bleed. Sometimes it's an incidental finding in babies when we do a CBC for no good reason. So in the first 3 cases, when we have a sick baby or a sibling history or risk factors, thrombocytopenia is what we're looking for and is hence expected. We don't really do much about it in terms of in evaluation. But when there is a bleeding neonate or when it's an incidental finding is when we all put our thinking caps on and go through algorithms and even start teaching during rounds. So the definition of thrombocytopenia is the same as in adults, even though the 1.5 lakh cutoff is the 5th percentile for normal values in adults. In premature babies, it could be lower as normal. The 5th percentile in preterm babies could be as low as 1.04 lakhs for babies less than 32 weeks and 1.23 for more than 34 weeks. This was found in some studies. But for all practical purposes, we still take 1.5 lakh as a cutoff. Generally, we classify it as thrombocytopenia according to the timing of presentation as early onset and late onset thrombocytopenia with respect to 72 hours of age. We could also classify in terms of increased destruction and decreased production as per platelet size or even mode of acquisition, congenital acquired. But none of these are really practical when you start working up. What we do, or what is the most important classification aspect, is first see whether the baby is sick or well. However, this itself has some shortcomings. Sick baby, a baby could be sick for other reasons which may not have caused a thrombocytopenia. So for example, a baby could have asphyxia or sepsis and could have autoimmune or alloimmune thrombocytopenia. Then the other shortcoming is a well baby. How many of us can with confidence say this baby is well? Only with experience we can do that. But sometimes soft features of sepsis can be missed. Hence, many times we do have to go through all the algorithms. Now, these are some complex algorithms which you find in textbooks. I will not go through it, of course, like this and confuse you. I'll be going it through step by step. So first what we see is it severe thrombocytopenia? Severe thrombocytopenia is defined as less than 50,000 count. Now, some authors have even gone to classify it further into very severe, where the risk of bleeding is much higher. Mild and moderate is 1 to 1.5 and 50,000 to 1 lakh respectively. Now, when there is severe thrombocytopenia, you have to take it severely, of course. Now, severe thrombocytopenia in a full-term baby is due to NAIT until proven otherwise. NAIT is neonatal alloimmune thrombocytopenia. It could also be sepsis or NAC. Now, first we look at sepsis. Conventionally, we look at maternal risk factors like chorioamnionitis and UTI. I often, however, say that in vaginal deliveries with no risk factors like prolonged rupture of membranes or maternal fever does not exclude the risk of infection being there. Only elective cesarean sections with no induction of labor, no labor, perhaps the chances are like really minimal that the baby has sepsis. Otherwise, everybody could have sepsis. In late onset sepsis, we look at risk factors like the presence of tubes or lines, or whether the baby is receiving breast milk, etc. But as such, a new late onset thrombocytopenia is due to sepsis unless proven otherwise. Now, thrombocytopenia is more common in late onset sepsis compared to early onset sepsis. And late onset sepsis with severe thrombocytopenia more often occurs in ELBW babies. Sepsis causes thrombocytopenia through both the mechanisms of increased destruction and decreased production. Increased destruction could be through DIC, which is very rare. It could happen in sick babies, but more commonly due to vascular endothelial damage, which causes platelet aggregation. It could cause damage to the platelet membrane as such through antibodies. It could cause platelet apoptosis. The bacterial products could adhere to the platelet membrane and cause platelet aggregation. Decreased production could also be caused with sepsis in the form of injury to megakaryocytes and suppression of the megakaryopoiesis by the bacterial products. So both the mechanisms are involved in sepsis. So we generally, because we cannot for sure say this baby does not have sepsis, we do a sepsis screen and start the baby on empirical broad spectrum antibiotics. But we have to go on. We can't wait for the blood culture to come back or the blood test to come back. So the next question would be, is it spurious, which is also called as pseudothrombocytopenia. thrombocytopenia. This we often suspect when we're not expecting thrombocytopenia, like in a well baby. So you have to go back and ask the pathologist, is this spurious? Excuse me. Pseudothrombocytopenia could be caused by EDTA-induced thrombocytopenia, which causes platelet clumping or platelet satellitism. Platelet clumping occurs because of some antibodies that go and attach to the antigens, which get revealed only in the presence of EDTA, and this causes platelets to aggregate. But platelets don't get activated, they just get aggregated and they clump up. Platelet satellitism occurs when platelets adhere to neutrophils in the presence of EDTA, again causing platelet clumps. Now, there are giant platelet syndromes where the platelets are, like, of course, giants. This occurs in Bernard-Soulier syndrome, May-Heglin anomaly, and Gray platelet syndrome. In both of this, where there is aggregated platelets as well as these large platelets, the machine that is usually counting the platelets will miss it, will not count it as platelets, and hence results in a falsely low platelet count. Now, how do you know that this is not real thrombocytopenia? To talk to the pathologist, they can do a manual platelet count and look for platelet clumps or the platelet aggregation that occurs, or even the giant platelets. Or if you're still not sure if it keeps clumping, then you can take a platelet, can do a platelet count in a tube or collect blood in a tube containing heparin or citrate. Now, for the specific diagnosis of EDTA-induced thrombocytopenia, it's easily done by collecting the blood in an EDTA tube, perform a platelet count right away, and then sequentially after 1 or 2 hours and more, and then you'll see a decrease in platelet count over time with exposure to EDTA, and this clinches the diagnosis of EDTA-induced thrombocytopenia. So once you know that this is real thrombocytopenia, start hunting again. Does the baby have any anomalies or dysmorphic features? There are many syndromes that are associated with thrombocytopenia. One of the classic ones, which is often asked in the exams, and which we all do end up seeing at least 1 or 2 cases or maybe more in our lifetime, is the TAR syndrome, thrombocytopenia absent radius syndrome. This is characterized by absent radii. So the forearms appear shortened and the hand appears flexed. The thumbs are normal in these cases, and the other characteristic feature is thrombocytopenia, which you will look for immediately after birth. These babies could have life-threatening hemorrhage. Over time, over 1 or 2 years, the platelet counts do improve. These babies could also have malformations of the heart and kidneys. They could have unusual facial features. Interestingly, half of these babies or individuals can have cow's milk allergy. Fanconi's anemia is another one that can be associated with thrombocytopenia. Here the difference is they could have skeletal deformities, but the thumb is normal in contrast to the TAR syndrome. Here the radii could be involved as well. Anemia usually precedes thrombocytopenia in these cases, and you may see cafe au lait spots and abnormal faces. Often this diagnosis is not made in the neonatal period, but much later. There are other syndromes that are associated with mild to moderate thrombocytopenia, like Down syndrome, trisomy 13, 18, Noonan, Turner, and Jacobson syndrome. These babies, of course, obviously look dysmorphic. You just have to do the genetic testing and you have the diagnosis. This is Kasabach-Merritt syndrome, where it's also called as hemangioma thrombocytopenia syndrome. This syndrome is characterized by vascular tumors which can occur anywhere in the body, usually occurs in the trunk, in the extremities, retroperitoneum, and cervical and facial areas. I had a baby with extensive involvement of the chest, abdomen, and the back. These vascular tumors can trap the platelets, resulting in thrombocytopenia. Not only that, the coagulation factors can get utilized over here, resulting in DIC. It could also result in microangiopathic anemia because the RBCs get physically damaged in these tumors. These babies can become quite sick, episodics, I mean. They could have intracranial hemorrhage, and the mortality rate is as high as 30%. Now, if the baby is normal, and you're still waiting for that sepsis workup reports to come, start looking further. Is it just platelets that's down, or are the other cell lines down as well? Now, neutrophils could be down in asphyxia and preeclampsia. WBCs can be very high or abnormal in HLH, can be low in HLH. Leukemia, it could be very high. Asphyxia can be associated with leukopenia. There could be anemia in babies with Fanconi anemia as well as HLH. So it could be more of a systemic disorder when there's more than one cell line down. If there's only pure thrombocytopenia or maybe perhaps neutropenia, well, look at whether there was perinatal asphyxia. Obviously, this diagnosis is obvious right at the start when the baby is born, but sometimes you may have to think about it as well. Here, asphyxia causes thrombocytopenia in the mechanism being decreased production of platelets. DIC could also be there in severe asphyxia causing thrombocytopenia. The incidence of thrombocytopenia in these cases with asphyxia is about 1/3 to 1/2 of the cases. They generally have mild thrombocytopenia, and the lowest platelet count is reached on day of life number 3. You may have to look for any evidence of viral infection next. Torch infection, for example, can cause thrombocytopenia. You can have features of IUGR, microcephaly, blueberry muffin lesions, maternal history of fever and rash, so on and so forth. So look actively for evidence of torch infection. Now, last year we had dengue, maternal dengue causing thrombocytopenia in babies, and now maybe even the COVID, who knows? So if you don't find any evidence so far of any of this, what you're looking for, just check the mother's platelet count. A baby can have thrombocytopenia when a mother has autoimmune diseases like SLE and ITP. Now, this is an immune-mediated thrombocytopenia where the maternal antibodies cross the placenta and react with the fetal platelets, destroying them. You could get a history of splenectomy in these mothers when the mothers have chronic ITP. In these cases, the mother's platelet count may be normal. So you may have to dig up in the history about the history of splenectomy. A sibling history of thrombocytopenia. Now, most babies who are born to mothers with autoimmune diseases have normal platelet counts or have mild thrombocytopenia. The incidence of severe thrombocytopenia is only 10 to 30%. The platelet count reaches its lowest at 2 to 3 days of age, and it resolves spontaneously. Mild bleeding could be seen sometimes. Important points to remember here is neonatal thrombocytopenia could be the initial presenting sign for the maternal autoimmune diseases. So when you're not finding any reason for the thrombocytopenia in the baby, please ask the obstetrician to look for autoimmune diseases in the mother. Other important point is that severity of neonatal thrombocytopenia does not correlate with severity of maternal thrombocytopenia. Then what next if you have not found an answer yet? Look at the drugs. Was the mother using any drugs during pregnancy, or is the baby on any drugs now? Now, both of this, there are some instances where there have been maternal drug-dependent antibodies which cross the placenta and cause thrombocytopenia in the baby. Now, these include anticonvulsants and quinidine. There have been case reports of maternal thiazide and tolbutamide use which have caused neonatal thrombocytopenia because of marrow suppression. Neonatal drugs, antibiotics can cause thrombocytopenia. I had a case like that about 2 months back. Heparin is the notorious one which can cause thrombocytopenia in a baby. This too, I'm sure we all have seen cases like this. This diagnosis is called as heparin-induced thrombocytopenia, which can occur at any age, be it baby or adult. There are 2 types of HIT, type 1 and type 2. HIT 1, which is also known as heparin-associated thrombocytopenia, is not a true immune-mediated thrombocytopenia. It is more common than HIT type 2. This is a non-immunological response to heparin treatment where there is a direct interaction between heparin and platelets causing platelet clumping or sequestration. You may see it in up to 10% of patients on heparin. This usually occurs within the first 48 to 72 hours after starting heparin. It causes mild and transient thrombocytopenia and often returns to normal within 4 days once the heparin is withdrawn. So this is a baby where you have you see thrombocytopenia, mild thrombocytopenia, and you don't have a reason, and then you realize the baby has a central line and giving heparin through it. You stop the heparin, and within 2 or 3 days, the platelet count is back to normal, and that is often clinches the diagnosis. There are no lab tests required, and this problem is not associated with the increased risk of thrombosis, which occurs in HIT type 2. Now, this is a true immune-mediated thrombocytopenia, which is very clearly described in adults and might be happening in our babies as well. In this situation, heparin binds to platelet factor 4, which is present in platelets. This induces the formation of antibodies in some individuals, which in turn activates platelets, which is cleared by the RES and causes thrombocytopenia. More importantly, platelet activation leads to thrombosis, which is known as HITT, heparin-induced thrombocytopenia and thrombosis, which is a major cause of morbidity or mortality in these patients. Now, this risk is higher with bovine versus porcine heparin. We use porcine in our units. Unfractionated heparin versus low molecular weight heparin, and it more commonly occurs in post-surgical. This is in adult patients. In adults where it has been clearly studied and described, up to 8% of patients receiving heparin are at risk for developing the HIT antibodies. Out of this, 1 to 5% develop thrombocytopenia. And out of this, 1/3 of them have thrombosis as a problem. Now, this has been reported in preterm babies also. Cases of aortic thrombosis and midgut gangrene have been attributed to HIT type 2. The characteristic features of HIT type 2 is moderate thrombocytopenia, which starts 5 to 14 days after initiation of heparin. This is important that this starts 5 days later, not 2 days like compared to type 1 HIT. But when you stop the heparin, platelets count starts to rise within 2 to 3 days and usually returns to normal within 4 to 10 days. The diagnosis is often made by ELISA antibodies or serotonin release when platelet aggregation is taking place or platelets activated. HEPA test, whereas heparin, which is heparin-induced platelet activation test. Not all labs do it. You have to find a lab that does it. But treatment is simple. Stop all heparin. If you're suspecting thrombosis, anticoagulants need to be used. Other than warfarin, warfarin is known to increase thrombosis. But the mortality rate in adults is quite significant, is 20 to 30%. Now, when drugs have been excluded, polycythemia is the next thing you have to think of. Now, we have seen cases where there is thrombocytopenia in polycythemic babies. The incidence of thrombocytopenia in these babies is as much as 51%, and severe thrombocytopenia occurs in 9% of these cases. The mechanism for causing low platelets is not clear. The treatment is simple, partial exchange, and usually the platelets come back to normal within 2 to 3 days. Look for placental insufficiency next. Now, of course, often we look for this in preterm babies initially itself, especially when there's a history of preeclampsia in the mothers. So in a preterm baby with maternal preeclampsia and the baby is fine with no risk factors for early onset sepsis and the baby is not dysmorphic, this is what is often thought of first. Now, the incidence of thrombocytopenia in cases with placental insufficiency is about 1 in 100 babies. The thrombocytopenia in these babies is mild to moderate and of early onset. The lowest platelet count occurs at 2 to 4 days and classically resolves by 7 to 10 days. In other words, means if the platelet count remains low after 10 days, there is some other cause. It is not due to placental insufficiency. There could be associated neutropenia as well. Now, after all this, when you've not found other reasons, you have to think of neonatal alloimmune thrombocytopenia. Remember, you have to think of NAIT first or maybe second in full-term babies with severe thrombocytopenia. F is also called as FNAIT, which is fetal neonatal alloimmune thrombocytopenia. This is the commonest cause of severe thrombocytopenia. It accounts for 3% of all cases of thrombocytopenia and 27% cases of severe thrombocytopenia cases. Incidence is thought to be reported to be 1 in 1,000 to 1 in 10,000 births. This is in Western countries. Here, this is very much similar to Rh hemolytic disease, where the mother does not have the particular platelet antigen, whereas the father has the antigen. The mother gets sensitized to this antigen, and these antibodies are of IgG type. It crosses the placenta into the baby and causes thrombocytopenia. However, the mechanism and timing of sensitization in NAIT is not clear. It has been found, or alloantibodies have been found in a pregnant mother in the first time pregnancy itself, in about 24% of mothers. It has been found as early as 17 weeks. So the mechanism, proposed theories is that fetal-maternal hemorrhage that occurs during pregnancy can result in alloimmunization. This is very much similar to Rh hemolytic disease. Also, placenta has been found to carry the platelet antigen. So this could sensitize the mother into producing antibodies. So with this means that the firstborn babies can be affected with NAIT. Recurrence, when a baby has already been affected, recurrence rate is 75 to 90%. That means it's exceedingly high. The incidence of intracranial hemorrhage in these babies is 10 to 25%. Up to 80% of this intracranial hemorrhage can occur in utero, and 54% occur in less than 28 weeks of gestation. So you may see a baby who's already bled in the brain and being born. Of interest is that mothers who have anti-HPA-1A antibodies of a particular subtype, a beta-3 subtype, have higher incidence of intracranial hemorrhage. Now, this is thought to be because these beta-3 subtype antibodies, they attach to the endothelium of the vessels, compromising the integrity, and hence ICH results. Now, this might explain why not all cases of severe thrombocytopenia have intracranial bleed. These babies could also have skin bleeding or could also have other major organ bleeding. The incidence is 47 and 2% respectively. The mortality rate is reported to be 10%. Neurological sequelae following ICH, they could be as high as 20%. Neurological sequelae include cerebral palsy, cortical blindness, mental retardation, etc. When do we suspect NAIT in a baby? In a well-appearing term baby who presents with unexplained thrombocytopenia in the first 24 to 48 hours of life, up to 7 days is acceptable. Beyond this, usually NAIT is not the diagnosis. This is with any degree of thrombocytopenia. Think of NAIT in a full-term baby who presents with severe thrombocytopenia or with the intracranial hemorrhage. Also think of NAIT in ill-appearing babies, especially if the severe thrombocytopenia is present and the thrombocytopenia appears to be out of proportion to the clinical illness or persists even when the clinical illness improves. In a case series of about 50% of babies were thought to have some other illness because they were sick and then later found to have NAIT. So it means that just because a baby is sick and you're thinking sepsis does not exclude NAIT. Often though, it is a diagnosis of exclusion. To do a lab diagnosis in India, it is quite tough. In fact, there may not be any labs in India that could actually look for the antigen and antibodies here. You could perhaps do a cross match between the maternal serum and the paternal platelets looking for aggregation. This could just tell you that yes, there is some HPA incompatibility. Antigen typing of the mother's and father's platelets is ideally done first. There are about 24 human platelet antigens. Now these are the ones that are generally checked for: 1, 3, 4, 5, 9, and 15. The common antigens, HPA-1A, this occurs in about 85% of Caucasians. HPA-5B occurs in about 10 to 15% of Caucasians. But in Asians, it is the HPA-4 that is reported to be common. But the percentage I don't have. Now, once the antigen typing is done, then the mother's serum can be checked for those antibodies to see if she has the antibodies. But however, maybe about 80% of suspected NAIT lack demonstrable HPA incompatibility, the one that you're doing the antigen typing of the mother's and father's platelets, because they check only for those antigens. So while you're working on the diagnosis, just look at the spleen as well, which is very rare in babies. Hypersplenism can cause thrombocytopenia. Splenomegaly can occur in hemolytic anemias, in congenital viral infections, and portal vein thrombosis. Now, if you still haven't found a reason for thrombocytopenia, it could be a rare cause. I have often worked for occult infections, so repeatedly doing CRP or blood cultures or urine infections, and make sure that there is, or abscess, that could be a cause for thrombocytopenia. Think of thrombosis, especially when a baby has catheters or has come with dehydration. IEM is thought of in a sick baby. MMA and organic acidemias are known to be associated with thrombocytopenia. It could be congenital genetic platelet disorders like congenital A megakaryocytic thrombocytopenia. It could be type 2B von Willebrand disease, where the von Willebrand factor has increased affinity to platelets. Congenital leukemia, HLH, neuroblastoma are also known to have thrombocytopenia. In all these above conditions, hematological disorders, you'll need the help of a hematologist to work up these disorders. Thrombocytopenia has also been seen post-exchange transfusion, because when the blood that you use for exchange transfusion is platelet poor, so it causes dilutional thrombocytopenia, which recovers in 1 or 2 days. So when you have a rare cause, when you have persistent thrombocytopenia, you have to work up in terms of, is it increased destruction or decreased production of platelets? Now, one of the shortcut methods that we use is check the platelet count 1 hour after transfusion. If it has fallen rapidly, that is, if it is if the rise is less than 10,000 compared to the previous one, it is most likely immune-mediated thrombocytopenia. If the platelet count has been substantial, then recheck a platelet count about 6 to 8 hours later. If it has again fallen substantially, it is most likely non-immune mediated thrombocytopenia. However, if there has been a good rise which persists after 6 to 8 hours, is most likely because of decreased production of platelet that has caused the thrombocytopenia. You can also look at platelet indices, the mean platelet volume, for example, which is the machine calculated measurement, which looks like the average size of the circulating platelets. When there is decreased production of platelets, the platelet MPV is normal, that is 7.5 to 9.5 FL, that is femtoliter. But when there is increased destruction of platelets, the platelet production revs up, and hence large platelets are thrown out into the circulation, very much like how reticulocytes are thrown out in hemolytic anemias. And immature platelets are large, so MPV will be 10 larger, higher, 10 to 12 FL. Reticulated platelets is another way of checking. These are platelets, these are the immature platelets. Immature platelets have higher content of RNA. So this can be measured with flow cytometry or with fluorescent dye studies. Now, immature platelets, of course, will be lesser in decreased production, so the RP count will be less than 2%, whereas it will be higher in increased destruction. Thrombopoietin level can be checked, which is a growth factor that gets utilized or gets bound to megakaryocytes and platelets. But if there is decreased production, the thrombopoietin does not get used up, and hence the level will be high. Whereas in increased destruction, thrombopoietin is easily used up, and hence the thrombopoietin level is normal. So this can help you differentiate between increased destruction versus decreased production. So when you suspect decreased production, you can go ahead with bone marrow investigation and a hematologist consultation. This is like a recap on flowchart on late onset thrombocytopenia. First question is a baby sick? If the baby is sick, you think of NEC, sepsis. Sepsis could be bacterial or fungal. If it is not sepsis, then you think of other causes which makes the baby sick, like leukemia, HLH, and IEM. If the baby is not sick, think of thrombosis, medications. thrombosis, especially if the baby has polycythemia, catheters, or dehydration. Medications if the baby is receiving any heparin or maybe even antibiotics. Rare causes you have to think of if you don't find any causes so far, like Fanconi's and genetic and torch. The flowchart for early onset was just too big to put in my slide. You can look it up in the books. So I'll come to management now. Management involves treatment of the underlying condition, platelet transfusions, and supportive. Now, in all cases of thrombocytopenia, especially in moderate to severe thrombocytopenia cases, avoid intramuscular injections because it can result in hematoma formations. Avoid heel pricks because bleeding can go on forever. If you want to do LP, it's generally recommended that you wait till the platelet count is more than 50,000. Otherwise, it results in a traumatic tap. No serious problems have been reported if you do LP in a thrombocytopenic baby, however. Remember to do a cranial ultrasound if the platelet count is less than 50,000. The treatment of underlying condition, these are the conditions where there is treatment, you will treat it, and the platelet count generally resolves within 4 to 7 days. This would include in sepsis, NEC, polycythemia, IEM, and drugs. All other conditions you will think, or even in these conditions, next question would be when should you transfuse the platelets? Frankly, prophylactic platelet transfusion has no role or benefit that has been shown in studies. But however, the risk, we all worry about the risk of spontaneous bleeding that can occur in the brain with these babies. The risk of intracranial hemorrhage increases with decreasing platelet count, the highest risk being in babies with platelet count less than 5,000. Babies who have platelet count less than or more than 1 lakh have zero risk of intracranial bleed. But it's not just the count that determines the risk of bleeding in the brain. It also depends on factors like gestational age. So ELBW babies are at higher risk for intracranial bleeds. It also depends on the day of life, younger babies. So these babies who are less than 1 week are at higher risk for intracranial bleed. Clinical condition of the baby. Babies who are unstable hemodynamically or who have other respiratory conditions, who are on a mechanical ventilator, are at higher risk for intracranial bleeding compared to babies who are clinically stable and still have a low platelet count. Platelet transfusion also is determined on whether the baby has also bled. And I put in experience as the other factor that determines whether the baby will get a platelet transfusion. Experienced clinician or neonatologist usually waits a little bit before thinking of platelet transfusion, especially if the baby has not bled, of course. Now, this is the guidelines developed or consensus. This is not evidence-based. No trials have shown this. And this is what you will see in most review articles and in textbooks. This is a table. I'll summarize it into this. If the baby has mild thrombocytopenia, do not transfuse. If the baby has moderate thrombocytopenia, do not transfuse unless there's a major bleed. If the baby has a severe thrombocytopenia, transfuse if the count is less than 30,000. Transfuse if the baby is very sick or unstable, or it's an ELBW baby or who is less than 1 week old, or if a surgery has been planned. And definitely transfuse if there already has been a bleed. Now, the type of platelets that you will use for platelet transfusion, they should be blood group compatible, preferably. They should be CMV negative if possible. Irradiated platelets are preferred if there is suspected immunodeficiency or if the baby has received in utero transfusions. In a case with NAIT, HPA compatible platelets should be used if possible, but in India, this is not likely. So the volume of platelet transfusion that is generally used is 10 ml per kg, which is infused over 30 to 60 minutes. In very sick babies who hemodynamically stay unstable, or in very small babies, you could use volumes as low as 5 ml per kg, or you could also give the platelets over 2 hours. 10 ml per kg is expected to raise the platelet count by about 50,000. Important point is do not transfuse platelets through central lines. Occasionally, in dire circumstances, you could use UVC, but never a PICC line. Platelets should be used as soon as possible, as soon as the platelets reach the unit. That means the IV line has to be ready before the platelets arrive in the NICU. While transfusing, shake the bag periodically to prevent settling down of the platelets. Now, diuretic is not indicated post-transfusion. Now, specific diagnosis, management, autoimmune thrombocytopenia. In mothers who have proven autoimmune diseases, all these babies should be screened at 24 hours or less. If it is mild to moderate, just monitor daily or every 2 to 3 days until you see a rise. If there has been a bleed or if the platelet count is less than 30,000, definitely transfuse with random donor platelets and IV and administer IVIG to the baby. The dose of IVIG is 1 gram per kg. Give it for 2 days. Important is to recheck platelet count in 2 weeks because antibodies still persist for up to 2 months and they could still continue to cause thrombocytopenia. NAIT, the treat management, specific management is, like I said, if the platelet count is less than 30,000 or if there has been a bleed when the platelet count is less than 1 lakh, definitely transfuse platelets. Ideally, it's the maternal platelets that need to be transfused. But however, to obtain and get the platelets ready from the mother takes time. Till then, you may have to transfuse RDP. If you can obtain HPA negative or compatible platelets, but like again in our country, difficult, till then transfuse RDP. Also administer IVIG 1 gram per kg for 2 days or half the dose for 4 days. Expect the counts to rise after 36 hours. You can also give steroids, but this has not been shown to be as effective as IVIG. The methylprednisolone can be given IV 1 mg per kg twice a day for 3 to 5 days. Platelets after this treatment typically recover to normal values within 8 to 10 days. A few words about fetal thrombocytopenia, that is in fetal NAIT. Now, as such, universal screening for allo antibodies is not currently recommended. And that is because, just take the example of HPA1A, that is the commonest antigen found in Caucasian mother or Caucasian population. The incidence of this, that is HPA1A being absent, is 2%. Out of this, or in this population, 10% only develop antibodies. And in the population that develops antibodies, only 30% of their children or babies have NAIT. And out of this, only 20% of these develop intracranial hemorrhage. So as such, universal screening for alloantibodies in Caucasians is not cost effective and hence is not done. But screening is generally recommended if there has been a previous affected child or if the maternal aunt's child has had NAIT. Now, mothers and fathers, antigen test screening is done as previously mentioned. But checking the titers may or may not be useful. I often trust the mothers who do not have HLA DR B30101, that's quite a mouthful. These mothers who don't have this HLA, they do not get sensitized to HPA. That is 1A. But again, this is also not routinely done. This is again just for interest's sake that there could be an association between HLA and HPA. Now, when you're suspecting NAIT, fetal HPA grouping can also be done by doing amniocentesis or obtaining cell-free fetal DNA from the mother's circulation. Now, the management of FNAIT is really controversial. When you have a mother, that is HPA incompatibility between the mother and the father, and the previous baby has been affected. This is what is generally recommended: maternal IVIG 1 gram per kg q week from 20 weeks onwards. Maternal steroid administration has also been tried previously, but then IVIG is currently a preferred treatment. Now, up-to-date authors have come up with this classification for management of mothers who had a previous baby with NAIT. They classify these mothers into low risk, high risk, and extremely high risk mothers. Low risk mothers are those who have had a baby with if with NAIT, but who has not had a intracranial bleed. So these remain at low risk for the second baby to have intracranial bleed. But in these cases, IVIG is started at 20 weeks onwards, and prednisone is added. No, either IVIG is done or IVIG plus prednisone is done from 20 weeks onwards. Whereas in high-risk mothers, where the mother has had the previous baby with NAIT and who's had intracranial bleed in the third trimester or after birth. In these cases, IVIG started much earlier at 12 weeks at 1 gram per kg dose, and it is increased to 2 gram at 20 weeks, and prednisone is added. But 28 weeks onwards, definitely IVIG at a higher dose and prednisone is given. In extremely high-risk cases where the mother has had the previous baby who's had a bleed in the second trimester, here intensive therapy is started with IVIG and prednisone right from 12 weeks with IVIG, and prednisone is added at 20 weeks. Now, once a mother receives treatment with IVIG, platelet count check is done for fetal through PUBS, that is percutaneous umbilical blood sampling, at 28 weeks, that is 8 weeks post start initiation of IVIG. If it is low, then intrauterine platelet transfusions are strongly considered to prevent intracranial hemorrhage. And the platelets that are transfused should be HPA compatible, or maternal platelets are the best. These platelets are concentrated and irradiated, and the volume to be transfused is calculated with a target count of 3 to 5 lakh in mind, because the depreciation of this platelet count occurs with time. So when they do the next platelet check in about 2 weeks, it would have reached about 50,000. Preferred platelets are HPA compatible and maternal washed platelets. The maternal platelets, if is used, needs to be washed to remove the alloantibodies. These mothers are advised to avoid NSAIDs and aspirin. Ultrasound should be done every 4 weeks looking for intracranial bleeds. Now, often a planned cesarean delivery is recommended, but this is controversial. There have been studies where vaginal deliveries have not increased the risk of ICH. But important point to keep in mind is keep maternal platelets ready for transfusion to be given to the babies postnatally. I've covered neonatal and fetal thrombocytopenia, the causes, the management. However, there are some controversies in this. The biggest controversy is, does platelet transfusion increase the mortality of babies? In babies with severe thrombocytopenia, there have been important studies that have been done, which I have put up on the slides, which have shown an increased mortality in babies with platelet transfusion. Now, this could be because platelets themselves are bioactive factors. They could have immunological and inflammatory effects and could result in increased incidence of death. Increased incidence of BPD has also been seen. Last slide on this experimental therapies that have been tried or are being under trial. The first one is recombinant thrombopoietin, which has been now abandoned because side effects of aplastic anemia were seen. Interleukin 11 has been tried in children and adults, especially those with cancer. Thrombopoietin receptor agonists are now being tried, but again in adult population, not in babies. Take home messages. You could be actually be home, so it could be stay home messages. Severe thrombocytopenia in a full-term baby is NAIT unless proven otherwise. Late onset thrombocytopenia in a preterm is due to sepsis or NAC unless proven otherwise. Neonatal thrombocytopenia may be the first sign of maternal autoimmune disease. Drugs can cause thrombocytopenia. Threshold for transfusion of platelets is 30,000, or if there's a bleed with a platelet count of less than 1 lakh. Recurrence of NAIT is very high in subsequent pregnancy, hence keep maternal platelets ready. Persistent thrombocytopenia, please involve the hematologist. So thank you for zooming on to me for this session. Thanks again.
Thank you, Dr. Archana. I'm sure you're going to have a lot of questions, because this is something which we come across in our practice, whether to give, not to give, and follow up, what advice to be given, how frequently we need to repeat the test. Indeed, comprehensively I've covered most of it, including the controversies and the latest therapy. Thank you very much. I request
thank you for the opportunity. And
yeah,
this is like, after a long time, not wearing a mask and speaking so much.
All right. Thank you very much, Dr. Archana. I request Dr. Deepak to start the session. So he'll be talking on the approach to bleeding neonate, and which is also something which we very commonly we come across. Over to you, Dr. Deepak.
1 minute, Prashant. Can you see the screen?
Yeah, we can see. We can see. Yeah.
Yeah. Thanks, Prashant. Thank you, Archana, for the fantastic talk. I'm one of the consultants working at Apollo Cradle. This we come across quite often in day-to-day practice. A neonate with bleeding, which can be scary, which can be sometimes, just benign due to swallowed maternal blood. So we'll go through the session today. So that today I'll be covering on neonatal hemostasis. It's quite important, to know the basics, and a bit about the coagulation cascade, about intrinsic pathway and extrinsic pathway in terms of the APDT and the PT pathway. How does a neonate presents apart from obvious bleeding? What are the other signs and symptoms we can pick up? And a very important thing is, how do we interpret coagulation tests in a baby, a preterm baby or a term baby? And the session would be like, we'll discuss some cases and also go through how to approach a bleeding neonate. And if time permits, we'll take a few minutes on special scenarios, and finally be happy to answer any questions you have for me. So we all know that the fetal hemostasis, the clotting factors start appearing around 5 to 10 weeks of age, and at term, around 50% of clotting factors are present in the baby. So, and the liver is the main organ for production of these factors, which are procoagulants, and it also produces anticoagulants like protein C, protein S, and antithrombin as well. So the key point would be like, the hemostasis continues to mature, and all the clotting factors reach adult values by 6 months. So which is quite important. In preterm baby, you can have clotting factors up to 30%. And there are some exceptions. Some of the things would be like factor VIII and also factor V, fibrinogen levels. These are within adult range. And also the anticoagulants like antithrombin, protein C, and protein S are around 30 to 50% of adult levels. So the neonate is at a relative fibrinolytic stage, but in view of increased von Willebrand factor and hematocrit and large polymers of von Willebrand factor, it doesn't experience clotting problems much. But in a sick baby, so this can cause problems. So this is coming to a medical school, so this used to be a nightmare for me, at least, the intrinsic pathway, extrinsic pathway, and the common coagulation pathway. So in simplistic terms, the intrinsic pathway measures your APTT, so which is very important. in hemostasis, and the extrinsic pathway is generally measured by the PT. And the common pathway is formed by the factor 10A, and then prothrombin is activated, and the prothrombin activation is the most important thing in the coagulation cascade. And the thrombin, in fact, it acts on the fibrinogen to form a fibrin clot. And very important is factor 13, this fibrin stabilizing factor. It helps in clot formation, cross-linked fibrin clot. And and with platelets, and it forms a clot. And this is a simpler way of looking into a coagulation pathway. So as I said, it's very difficult for me, at least, to remember all the clotting factors. Good luck if you can remember it. In the end, there will be a prize for somebody who can name all the factors, if they can memorize. But the main important point would be, as I said, the intrinsic pathway, you have collagen, which with the surface contact factors like 12, 11, 9 activates 10, and you have the red lines here, various factors with calcium helps to complete this pathway. And extrinsic pathway is generally comes into play when a vessel is injured, when there is an injury, and then it's formed by tissue thromboplastin, and factor 7 is activated, and then in fact then the common pathway starts from factor 10. So as I said earlier, thrombin is activated, and then fibrinogen, fibrin, and then fibrin is cross-linked with factor 13 and forms a clot. So there can be many things that can go wrong, but the take-home message would be like, intrinsic pathway is very important. So moving on, just a few points about how does a neonate present with, when there is a major bleeding or inside bleeding. The bleeding can happen before birth also. This is true in case of fetal maternal transmission, this hemorrhage or twin-to-twin transfusion. And when there is an accident with placenta, something like vasa previa, cord accident, or placenta previa, abruption, you can have loss of clotting factors and loss of blood. And a baby can also have an intracranial hemorrhage before delivery, very rarely due to some deficiency of clotting factors that we'll come and discuss it later on. And at times, so if it's a difficult delivery, you can have a big cephalhematoma and subgaleal hemorrhage. It's very important, with the vacuum delivery or traumatic delivery. Sometimes, so the blood collects in the subgaleal region, the subaneuritic region, which can accommodate large amounts of blood. So very important to recognize this condition. And I think Dr. Guru Prasad touched upon it in his talk earlier. The important thing is this can also cause low platelets and loss of clotting factors. So very important to recognize this condition and treat aggressively. Does a neonate present with bleeding? So if it is like a hidden compartment, like intracranial hemorrhage, or if it's in the liver or abdomen, so it can present with shock, anemia, or cardiorespiratory compromise. But in other common things would be from the gastrointestinal tract, or you can have a pulmonary hemorrhage, and more commonly you would see a bleeding from the skin surfaces. So if you're doing a heel prick, if it's prolonged bleeding, or umbilical oozing from your umbilical cord, that could be a sign of a problem in a baby. And also, it's very important to note down swallowed maternal blood when investigating a GI bleed in a well baby. So we'll come to the end. So whenever baby looks well and there is a history of placenta previa, and you have a lot of blood passing through upper GI tract or vomiting, or when the baby passes blood through per rectum. If it's a well baby, then one should be aware of this swallowed maternal blood. And it's very simple that how you differentiate swallowed maternal blood by doing something called APT test. So this is very important. How do we interpret, PT and APTT? If you see a PT in a term baby, a prothrombin time, it can be around 14 to 15 seconds. And APTT would be around 34 to 45 seconds. But coming to the extreme preterm, in let's say that baby is born at 24 or 25 weeks, the APTT can be around 87, which is quite normal for a 25 or a 26 week. And PT also can be a bit longer. So this is very important in investigating and interpreting a cause of bleeding, and also it influences how we treat a baby, not only on the basis of investigations or abnormal reports, and also we should consider the gestational age and the maturation. So this is just to show you that the PT and APTT will normalize around 6 months. These are the adult values, and pretty much all the clotting factors, as you can see, are reach adult values by around 6 months of age. So in summary, so the clotting continues to mature, the clotting factors, and it reaches adult values by 6 months. At neonate, most of the clotting factors, apart except your factor 8, fibrinogen, are around 30 to 50% of adult values. So then comes the next thing. What is abnormal? So this is in a term baby. This is from one of the journals. What you would take is any bleeding baby if INR is 1.5 or greater in a term baby, or if APTT is more than 60 seconds, then this would be considered as abnormal. Fibrinogen less than 1.5 grams per liter. Ideally, you would want to keep it above 1 gram. So you would think I would take it as significant. Platelet count, I won't dwell upon much because Archana has already talked about it. This FDP, fibrinogen degradation products, they are present, but this is not, we don't do this test that often. The reason is it can be elevated in neonate in first 3 days of life, and might be difficult to interpret also. So the next question would be, when do we screen or test for coagulation abnormalities? This is an interesting topic. Do we screen all babies, all preterm babies? Probably no. But if a baby is very sick, so hypotensive, a sick preterm baby, then one would investigate and send coagulation screen in such babies. So any bleeding baby, yes, you should send for a coagulation screen. And if there is a family history of inherited bleeding disorder, there is a caveat in it. You shouldn't be, you can't investigate all the bleeding disorders. But if there is something like hemophilia, and if you can know the genetic problem, then you can investigate. Something like von Willebrand disease type 1 and all, there is no need to investigate in a neonate. So, but you would discuss this with a hematologist and take the advice. So any severe metabolic disease, severe respiratory distress syndrome, something like severe meconium aspiration syndrome with PPHN, these things you would, one should send a screen for coagulation. And any liver dysfunction, prolonged TPN, biliary atresia. So these are the factors wherein you would expect coagulation abnormalities. Here, one would screen for these coagulation abnormalities. And more importantly, babies whose mothers are taking anticonvulsants, warfarin, this can interfere with vitamin K metabolism and antituberculous drugs. So these babies are at risk of having a vitamin K deficiency, and they can present with bleeding on day 1 or day 2. So very important then, if there is a mother who is on these medicines, you should screen the baby on day 1, even if the baby looks well. So other one would be like all neonates undergoing surgery or tissue biopsy who have had previous bleeding problems. So how do we approach a bleeding newborn? The first one would be the history. If you have time, you note down whether vitamin K has been given, and take a maternal history. Has she got any problems? Is she taking any medicines? Archana covered about ITP and all, so any immunological problems, what is mother's platelets. So you take a focused history and move on to the physical examination. So very important, as Archana talked, very important to know that baby what you are dealing is well or sick. So your management will depend on whether the baby is well or sick. And other factors like, if you have a hepatosplenomegaly, it could be torch infections, and the bleeding sites. The bleeding sites may not tell you much, but there are certain clues that one can gather from the bleeding sites. If there is a oozing of umbilicus, so persistent oozing from the umbilicus, then you can think about your fibrogen deficiency or factor 13 deficiency, which are very rare. So the petechia may point out to either platelet being low and physical abnormalities. This I think Archana covered in the previous talk, something like TOS syndrome, or if you have any discrepancy in the arms, think of Kasavik-Marit syndrome, hemangiomas. So you would do a quick examination, look for cataracts, head to toe examination, and document if you find any of the abnormalities. So the approach would be the same: airway, breathing, circulation, you deal with it. And the first line investigations for most bleeding infant would be your blood count, peripheral smear, mainly blood count to look into hemoglobin and platelet. Peripheral smear, you can make out whether there is a hemolysis. Certain things can point out to mainly the platelet pathology, prothrombin time, and APTT and fibrinogen. So this would be suffice in most of the babies. And if there is a sick baby, obviously you will take blood cultures and other tests you would do it, CRP and other things. The second line investigations, suppose you were struggling with the baby in terms of bleeding, and if the clotting is not getting corrected, then you would go ahead and then do the secondary investigations. Suppose if there's a clear family history of bleeding problems, then you would send these in the first line as well, like something like factor assay. And most important thing is that what the hematologists and the labs do is they do something called mixing studies. So they mix 50% of plasma to the blood what you have sent and see whether the PT and APTT gets corrected. If it gets corrected, then it tells you that the clotting factors are deficient, and then you can send for the factor assay. Suppose if it doesn't get corrected, then you have to think about other diagnosis. Is it heparin contamination, or is something rare, something like factor 13 deficiency? Those things you need to think of. So let's quickly go through some of the case studies which I have encountered in the last couple of years of my practice. This was a case which we recently encountered. This baby had a malrotation and a midgut volvulus, presented to us on day 9 of life, and went for operation. And post-op day 2, this baby was extubated and was doing well. And as you can see, the baby had a something like a red currant jelly bleeding per rectum. So it was a bit scary for the registrar. But the baby was clinically looking well. The abdomen was soft, and so his vitals were stable. So we sent a clotting screen. PT was slightly abnormal. This is a term baby. APD was probably within the normal range. The hemoglobin, there was no drop, and platelets were normal. So we gave a IV vitamin K slowly, and the ultrasound abdomen was done, just mainly to look into interception or the blood in the gut viability. So the SMA blood flow was normal in the Doppler. They were happy. So we just observed the baby, and the baby recovered. And this baby went home on post-op day 7. So in contrast, you can encounter a sick baby. So this is a moderate preterm and developed abdominal distension, and so not handling well, and this platelet count was quite low. It was around 45,000, and this baby was put on triple antibiotics and nilbymouth and parenteral nutrition. Was doing reasonably well. Blood gases were okay, but suddenly it around day 3 with acidosis and shock. On the screen on the right hand, you can see the blood in the NG, the dark aspirates, and also this baby also had a hematemesis in spite of this upper GI bleed, in spite of aspirating it, and this baby had abnormal coagulation in spite of correcting multiple times. So the platelets were low. PPD was twice the normal range initially, and then continued to be abnormal. In spite of ventilation, inotropes, blood products, antibiotics, this baby died after 48 hours with refractory shock. And so this baby also gave Klebsiella in the blood culture. So the diagnosis was pan-necrotizing enterocolitis and DIC. So bleeding can be serious in sepsis and DIC. It could be one of the things wherein in India, it could be the common cause of bleeding. Excuse me. So this was quite interesting. So this is probably 4 years ago. Some surprises happen on postnatal ward rounds. So as usual, you just ask, is there any family history of any problems? So in that questioning, that mother told me that her brother had hemophilia, so nobody probably had taken the history previously, and this baby was absolutely fine. But you can't ignore that the maternal uncle had a hemophilia. So we sent a clotting screen, and the EPDD was very abnormal for a term baby, and sent a factor assay along with von Willebrand factor, and this confirmed, this was confirmed after 3 months of age, and baby had a moderate deficiency of factor 8. This was a diagnosis. The diagnosis was hemophilia A, and it's important to know this because some of these babies can have around 5% of them, they can have intracranial hemorrhage. So we got the cranial ultrasound done before discharging. Very important while giving injections, how you give injections, use a smaller needle, and liaison with the hematologist is very, very important. And this baby is doing well. He's around 4 years now, required factor 8 concentrate 3 or 4 times. And very well-educated family. In fact, the maternal uncle, he's the president of Hemophilia Society in Andhra. So he's doing fine. And subsequently, we got the genetic counseling and testing for the second, the fetus, and she went on to deliver a healthy, unaffected baby at full term. So coming to laboratory investigation of neonatal coagulation disorder, very important, as I told you earlier, sick baby or a well baby. Well baby with the bleeding, it could be vitamin K deficiency, or it could be an inherited disorder of coagulation. So if you look into the PT and APTT, PT abnormalities, you can have prothrombin time that is extrinsic, factor 7. It can also test common pathway, factor 10. So isolated increase in these things can give you a clue. So then you can go on to do factor 7 assay or factor 10 assay. Hemophilia, the intrinsic pathway will be prolonged. APD will be prolonged. Then you can do a mixing test and then see whether it gets corrected, and then subsequently factor assays. Factor 13, I think it's examiners, you get to hear a lot about in the exam. Very rare, but all the clotting tests, what you do would be normal here, so and the screening for this assays are not widely available, but you can speak to the hematologist and then they can do whether the clot solubility test in urea or chloroacetic acid, and they can give you a clue, and then you can come to a diagnosis. Then there are acquired disorders like DIC or liver problems. Here in DIC, as we talked earlier, all the parameters will be abnormal. Fibrinogen level will be low, platelets will be low, your PT, APTT will be high. Coming to vitamin K deficiency, we'll discuss later. The PT will be, prothrombin time will be increased earlier, but in severe cases, both PT and APTT can be increased. Not necessary to do all these factors here, but you can do something called PUCA2, or the most important thing would be whenever you suspect a vitamin K deficiency, don't wait for the tests. You give the treatment, very simple, and see whether this within a couple of hours, generally the clotting normalizes, and you repeat a clotting and see whether the clotting is corrected. That's the best way of diagnosing vitamin K deficiency. Coming to liver disease, yes, you will have some other clues there with your albumin being low and the liver enzymes being abnormal. Yeah, this is one of algorithms. How do you approach a bleeding neonate, sick or well baby, sick baby? Yes, so you can check platelets, PT, APTT, fibrinogen, give vitamin K. Patient in DIC, then you treat the underlying disorder. Thrombocytopenia, Archana has covered, we won't go there. Then this we have talked about earlier, isolated PT prolongation, factor 7, isolated APTT, you check your hemophilias, factor 11, and factor 9 and factor 13 activity also sometimes can cause this, isolated APTT. And also PT and APTT prolonged, this we have gone through already. And when there is a normal clotting, then you have to think about other things. So whether you're dealing with factor 13 deficiency or some platelet function disorder. So, and von Willebrand disease also sometimes can present with normal clotting. A word about vitamin K deficiency. So as we know that the three types, early one is common if mother is taking anticonvulsants, antibiotics. So it presents with in first 24 hours. Very important that you treat this aggressively. Treat with vitamin K and also your FFP or concentrate, prothrombin concentrate early. So don't wait for the factor assess whenever you suspect vitamin K deficiency. In fact, in all babies, if the baby is sick and then bleeding, first thing would be you take samples and give vitamin K. Classic disease happens 1 to 7 days. Fortunately, this is rare in the era where we give vitamin K for all babies. But I'll come and show some data later on. But this, you should have a high suspicion. In some, we can still see the classic disease also. It's very well known in breastfed babies. And that's the reason that we recommend vitamin K IM for all breastfed babies. And the treatment is, vitamin K 0.5 to 1 mg, slow IV, or if there is a bleeding, if you can't get a IV cannula, you can give subcutaneously. In the late onset, you would see in babies who's having liver problems, biliary atresia, cystic fibrosis, and if the baby is on prolonged antibiotics or prolonged TPN, you may notice vitamin K presenting as bleeding later. So this just to re-emphasize that all healthy newborns should receive vitamin K 1 mg intramuscularly at birth. If they refuse it, you won't see it in India, but in Western countries, some parents, you would come across this, that they don't want vitamin K IM because of one study quoted increased risk of cancer. So that you have to document it. And this is then these babies, then you can give orally vitamin K. But oral vitamin K is not absorbed properly, then you have to repeat the doses. So how does an inherited coagulation disorder present in a neonate? So it's a well baby, and you would notice bleeding from vena puncture or heel streak. This is from American data. We don't do circumcision, but America circumcision is quite commonly done soon after delivery. The post-circumcision bleed can happen 48%. This is from one of the papers. They quote higher incidence around 19% of bleed, but this intracranial hemorrhage is around 20-25% is more common with your factor 13 deficiency or fibrinogen deficiency. With this, you can have a intracranial hemorrhage. So hemophilia, the risk is around 5%, they say. And von Willebrand disease, generally type 3, which is autosomal recessive, can present in neonate. So the most common inherited coagulation disorder which presents in a neonate is hemophilia. So coming to the DIC, so I think in India, this is probably the commonest cause of bleeding in a sick baby. So there are several causes, sepsis, it could be viral, bacteria, or a fungal. And if there is an event, perinatal event, something like birth asphyxia, a severe respiratory distress syndrome, Meconium aspiration syndrome, then can present like DIC picture. Very common in twins, wherein one twin has vanished or is dead, And obviously, if you have hypothermia and acidosis, this can present this as DIC as well, severe acidosis. So management would be finding out the underlying cause and treating it. General guidelines, the key platelets above 50K. FFP, you replace it like 10 to 15 ml per kilo, and you recheck it in a very sick baby after 2 to 4 hours. Or if the baby is stable, you can check it after 12 to 24 hours. Cryoprecipitate provides your fibrinogen. If the fibrinogen is less than 1 gram, then you can give 5 to 10 ml per kilo of cryo. I think we're coming to the end. So the special scenarios wherein anticoagulation is commenced. This one can see if you have worked in a cardiac units, if the baby is on ECMO or if they have done cardiac procedures, there is a significant risk of thrombosis. So these babies are put on heparin. And sometimes bleeding can be a problem, but you should follow the unit protocols. For all babies on ECMO, they're on heparin. We do something called you can't measure the clotting frequently, so you need to be bedside and then measure something called ACT, and then see the range, and then they adjust the heparin. Usually the perfusionist, they monitor these things. And there's something called TEG also they use in ECMO units, wherein you can get the function of where you need to act quickly. So the TEG will give you an idea whether this is a problem with your fibrinogen or clot problems, so then they can treat. Not talking about neonatal thrombosis, because it's a separate topic on itself. But a few words, sometimes, the hepatologist commends these babies on heparin, low molecular weight heparin. And this has happened in a couple of cases I've seen wherein, there can be a drug error. So people have given 10 times the dose of low molecular weight heparin, enoxaparin. Enoxaparin also then dosage, then what to do. So in that case, you have to contact the hematologist, do basic clotting tests, and then correct it. And these babies, they measure something called factor 10A levels as well. But this is beyond today's topic. We won't dwell much on this, but any questions, I would be happy to take it later on this. So in conclusion, one has to interpret coagulation tests according to the gestation age. PT, APTT in a preterm baby can be quite abnormal for a term baby or a 3-day-old baby. The normal in a preterm baby can be abnormal. So that you have to remember. So simple things, APTT tests intrinsic pathway and the common pathway, and prothrombin also tests extrinsic and intrinsic pathway. There are simple algorithms for sick or well baby with bleeding, which helps you in arriving diagnosis. So very important, when you are in doubt, always seek advice when an inherited bleeding disorder is suspected. So speak with the hematologist. A few things about practical aspects of collecting and processing sample, very, very important. You are dealing with a very small baby, and as residents, we all have experienced these problems. You collect a sample, and an hour or 2 hours later, they call back and say that you had to resend the sample because it's insufficient or there is a clot. And also some other things like venous sample is very important to send. And if you have an arterial line, take out a good sample, like around 2 or 2.5 ml minimum. Some say 4 ml also before taking the sample for clotting. So these are very important things one should not forget while interpreting these tests. And those who are savvy about the web and internet, there is a website, coagsuncomplicated.com. So you can just put your the age of the baby and the PT and APTT and the platelet count. It will tell you what to do. Yeah. These things are also available. I think it's available as an app as well on mobile. This we will skip. The sample collection, I talked about correct volume, type of sample. Very important, beware of the high hematocrit. Ideally, it should be 1 part citrate to the 9 parts of the blood. And coming to the last slide, what is the incidence of bleeding in the country? It's probably around 4%. And very common in very low birth weight baby, around 14%. And coming to the etiology, sepsis and with DIC, this is one of the papers from PGIMR and from Delhi group, Swarnim et al. So in their group, they analyzed around, I think, 1,400 babies. So 40% of them babies had septicemia or DIC. Vitamin K deficiency bleeding was common as well, around 17%, followed by birth asphyxia. And few cases of coagulation defects also they had, around 2 cases, and 1 case had a factor 13 deficiency. I think with this, I'll end my talk. I'm happy to take any questions.
Yeah, thank you very much, Dr. Deepak. So I request, and it was wonderful presentation though. So I request Dr. Girija, the moderator for the session, who is assistant professor at Vaidya Institute of Medical Science. Dr. Girija, over to you.
Deepak sir, both the talks were good. Ma'am, the question is for Archana ma'am. Can you hear me, ma'am?
Yeah, I can hear you.
Yes, ma'am. The question is for you. The role of methylprednisolone alone therapy in thrombocytopenia in NATE. Is it proved?
Not proven, rather, I would say methylene steroids are recommended only if IVIG is not available. Otherwise, it's always IVIG. Steroids used to be tried earlier, not successful in all the cases, but IVIG is very much preferred.
Okay, ma'am. Thank you. And question for you only, Archana ma'am. In
Yes.
the blood bank, if the random platelets doesn't work, if the IVIG doesn't work, is there antigen negative platelets available in India?
What is the question? Is it available in India?
Yes, ma'am. Antigen negative platelets.
No, because I checked with the hematologists. There are no labs that check for platelet antigens. Maybe the Mumbai National Institute of Hematology does it, but as such, there's no lab in India that checks for human platelet antigens. So you won't get antigen negative platelets. It always be random or single donor platelets.
How can a maternal platelets can be used in NATE, ma'am?
So the maternal platelets, we will not have that particular antigen for which the antibodies have been produced and has caused bleeding in the baby, thrombocytopenia in the baby rather. So if we transfuse maternal washed platelets, that is after removing the antibodies, these platelets will remain in the circulation because they will not be destroyed by the circulating antibodies that are present in the baby. So the baby's platelets levels will remain a little high till the antibodies are cleared off.
Okay, thank you, ma'am. Question for you only. Any test in India for NATE, ma'am, or it is solely on diagnosis?
It is solely on the diagnosis of exclusion, but some cases with the consultation of hematologists, you can do cross-matching of the mother's serum, that is with antibodies, and the father's platelets, and see if they, what we say, cross-react or aggregate. So if they aggregate, that means there's a reaction. That means that the mother has antibodies against a particular antigen. But that, of course, does not always mean that the baby has that antigen. You'll have to do further studies. Unfortunately, not possible in India.
Okay, thank you, ma'am. The volume for platelet transfusion, is it 10 or 20 ml per kg?
Generally 10 ml per kg. 20 ml, some people do transfuse, but then if it is immune-mediated thrombocytopenia, the platelet count can reduce fast. So massive bleeding, maybe 20 ml per kg can be given, but generally 10.
Okay, when to repeat for the platelets, ma'am, after transfusion? For
That depends on what you are suspecting. There's no studies done on that or recommendation as to when exactly should you repeat. I generally repeat after 6 to 8 hours if it is moderate to severe thrombocytopenia. Once I have 2 to 3 values, then I know the trend. Then I will base my interval on that.
Okay. How long to follow up in NATE, ma'am?
How long to follow up the platelet levels? Okay. Generally, the platelet or thrombocytopenia resolves by 2 weeks. Most cases, within 7 days itself, you'll see a rising trend because the antibodies are cleared from the circulation. So by 2 weeks.
Okay, thank you, ma'am. Question for you only. You have talked about antenatal management of pregnant women with previous history of NATE. You have told to start on IVIG or on steroid at 12 to. You have categorized in a high risk, low risk. Okay, ma'am. Up to how many weeks you are supposed to give IVIG and steroids?
Generally given till the baby is delivered.
Till the baby is delivered, ma'am?
Yeah.
Okay. Thank you, ma'am.
Welcome. My pleasure.
Yeah, thank you so much. Question for Deepak, sir.
Yes, Girija.
Sir, is the orally available vitamin K in India, and what's the brand name, sir?
No, I don't think it's available. You give the same IV. So whatever you have, no, the IV preparation, it can be given orally. We don't have the oral preparation. That's my understanding.
Okay, so how many doses of vitamin K can be given, sir, and when to repeat?
Is this for with regards to oral, you mean?
It's not regard to oral, sir. It's IM or subcutaneous.
So the prophylaxis dose is 1 mg. Okay. So in preterms, it can be a bit lesser, 400 micrograms per kilo, but you can follow your unit protocol. So you give the 1 dose, but suppose if there is no bleeding, I would repeat it. Suppose if there is a vitamin K deficiency, bleeding, then the 1 mg, you can repeat it every 8 hours until the bleeding stops. But more importantly, you would be measuring your PT and APTT. If the prothrombin time is less than 14 seconds, it literally rules out your vitamin K deficiency. And in terms of oral vitamin K, I put the slide. Can I share it again or for you and for the viewers?
Yes, sir. Can share it again.
So it's generally vitamin K. Let's see where it is. Can you see it or you can't see it? 1 minute. Let's start sharing. Sharing is there. Share screen. Yeah. So it's 2 mg orally you can give it at birth. Repeat at 4 to 6 days, and once at 6 weeks. There is one more like 2 mg weekly dose, 1 mg orally weekly dose for 6 months. This is for breastfed babies. Very important, So for breastfed babies, if they refuse to take vitamin K by IM, then you can take you can give them oral dose. But very important that it needs to be documented. Oral vitamin K is not that effective. And if you want to give oral vitamin K, you give you continue to give it either with 2 mg dose after 1 week and after 6 weeks, or weekly dose of 1 mg orally for 6 months.
Thank you, sir. Is there a role of cord blood for coagulation studies, sir?
Yeah, that's an interesting question. Yes, you can do it. If suppose if a mother is known or if there's a family history of inherited coagulation disorder, something like hemophilia, or a severe disorder initially, then you can send cord blood, but that will be with discussion with the hematologist. So you can look for the factors, because placenta, it doesn't transfer your coagulation factors from the mother. So you can send a cord blood, but I would discuss this with the hematologist. So I think in one occasion we had sent in India the cord blood also, but Western countries it is commonly done. Cord blood is sent, especially if there is a family history of bleeding disorder.
Okay. Sir, is there a role of bleeding time in neonate?
I have not done it, but bleeding time is shorter compared to the adult. People have moved away from doing bleeding times. So I have not done it in the last 15 years. If somebody, Archana, has done it, then she can share her experience. But no, we don't do it.
Okay. Should vitamin K repeated in a baby on prolonged antibiotic therapy, sir? Example, meningitis.
That's a good question. Suppose if the baby has had a vitamin K IM injection, then you are giving the dose, right? Why would you want to repeat it? There are like if you have a liver problem or others, then I think 1 mg of vitamin K is repeated every week or prolonged TPN. But for antibiotics, prolonged antibiotics, I'm not sure whether you repeat it, especially if you're given it IM. Suppose if the baby is on a formula feed, so I won't repeat it because formula contains a lot of vitamin K. For breastfed babies, there may be a rule, I suppose, but you are giving vitamin K. If they had given it IM, in my practice, I have not repeated it. So I probably have seen around 6 or 7 meningitis in the last 5 years. We have not repeated it, vitamin K.
Okay, is there a role for unfractionized heparin in bleeding, sir? In a bleeding neonate?
If there is a bleeding, why would you want to give heparin? That's probably, the question would be like, would you give heparin in a DIC kit, right? Yes. So in a DIC, I suppose if there is no bleeding and there is a role of the heparin, so some people do infuse heparin continuously. But suppose if there is active bleeding, then one would not give it.
Sir, a question for you only. Are there any guidelines on platelet transfusion? It's for ma'am, Archana ma'am.
Yeah.
Are there any guidelines on platelet transfusion in neonates with thrombocytopenia on therapeutic hypothermia?
Oh, yeah. Generally, it is recommended that you keep the platelets more than 1 lakh. But you have to look at the trend and then decide. Therapeutic hypothermia does worsen thrombocytopenia in a baby who has it with a post-asphyxia.
Okay, ma'am. I have a question for you only, ma'am. When to suspect line-induced thrombocytopenia and how to prevent it, and any specific treatment for it other than removing it?
when to suspect line-related thrombocytopenia would be when you are incidentally found platelet count to be low and you did not expect it and you can't find a reason for it. So generally we think of sepsis or, is there any other reason like autoimmune or alloimmune, all those things. And if you can't find a reason, the next trial would be just remove the heparin from the line and see what happens. And usually the platelet count recover by 2 days, 2 to 3 days, and then you know the diagnosis. And prevention as such is don't use heparin, but then you're risking thrombosis, especially in PICC lines.
Okay, ma'am. Thank you. Question for Deepak, sir. Is there a difference between term and preterm values for prothrombin, that is
Voice breaking, Girija.
before and after vitamin K?
Can you repeat that? There was a lot of disturbance. Sorry.
Sir, is there a difference between term and preterm values for PT, APTT before and after vitamin K?
Yeah, so I think once if you have measured your PT and APTT, and especially if PT is quite abnormal, due to, let's think that this is due to vitamin K deficiency, then that should correct within a couple of hours. So you would, when you repeat it, your PT will get corrected. In severe cases of vitamin K deficiency, APTT can also be affected. So that would also be reversed. So ideal practice would be like if you have a bleeding child and when you suspect vitamin K, severe vitamin K deficiency, you give vitamin K and repeat your clotting after 2 to 4 hours and see whether it's corrected. But in severe bleeding, then you would go ahead and then give FFP as well. Yeah. So don't wait for your PT and APTT, especially if it's early. If the vitamin K deficiency presents quite early, this can present as intracranial hemorrhage as well. So whenever you suspect a bleeding, you get a head scan done. And good practice in severe bleeding would be to give FFP as well.
Okay, thank you, sir. Over to you, Prashant, sir.
So I think we are coming to the end of discussion. So if anybody has any question, they can raise their hands. We will unmute them and we'll take up the question. I think most of the things with the presentation itself got cleared. And there were a few practical doubts which our moderator, Dr. Girija, has cleared. So if anybody has any question, before we close the session, we would like to give an opportunity for the participants to raise their hands and interact with our speakers directly. You can raise your hands. We will unmute. Yeah. Anyway.
Naresh is there, I think. Chat one, I can see someone. Dr. Naresh.
Dr. Naresh has raised hands.
Chat one, something is done. No?
Naresh from Rangadore. Yeah, Dr. Veera Manindra Singh, you can ask the question.
So, sir, what are the ideal target for platelet transfusion? Hello?
Yeah. We can hear you. You're asking the ideal target. So when you're giving platelet transfusion.
For platelet transfusion, we have so many units which having 10,000 platelets, but no bleeding. Whether transfuse or not?
These are consensus guidelines that have been developed. So if the platelet count is less than 30,000, especially in the first week of life, then the platelets have to be transfused. But if the baby is stable and more than 1 week of life, you got to see the trend of the platelet values and then decide. Of course, there are those anecdotal reports where babies have had platelet counts of 10 to 20,000 have not bled at all. But it's risking it. If it is a new onset thrombocytopenia, definitely transfuse. But the baby has had such severe thrombocytopenia for days, maybe then you have to consider whether to transfuse or not. And look at the etiology also.
All right. Thank you, Dr. Veer Mahendra. We have Dr. Naresh from Antenatal Hospital. Dr. Naresh?
Yeah. I'm audible?
Yes, yes, yes.
Yeah. So question to Deepak sir. I just put the same thing in the chat to Deepak sir. So in the clinical practice, so for in sick preterms, what value of PT INR like you transfuse the FFP? So
Yeah, very good question, Naresh. I was dreading this question because there's a lot of evidence if the whether even the bleeding IVH can occur normal coagulation as well. So if you ask me in a well preterm, do I do a clotting test? I won't do it even for a 25 or a 26 weeker or 27 weeker. But suppose if the baby is hypotensive, or if you have a grade 2 IVH or grade 1 IVH and hypotensive, so then if you do a clotting test, then if there is a sick preterm, then you would correct it. If the baby is quite bruised at birth, right, or if the baby is hypotensive or bleeding, so then you would do a clotting test. And if it's abnormal outside the range, 1.5 times your normal range. So let's say less than 28 weeks, probably in a sick baby, if the INR is more than 2, yeah. So or if APDD is more than 70 or 80, then and especially if the baby is bleeding, then I would go ahead and then transfuse it. Whether this is like it makes prudent to transfuse the baby because you are hoping that you are preventing further extension of the bleeding. Yeah, whether it will help it, I don't know the answer. There is no evidence behind it. So the simple question would be, like, that preterm baby, don't do coagulation necessarily. If it's a sick preterm baby, yes, you do a coagulation test. And if it's 1.5 times the normal range, yeah, then go ahead and then transfuse. For a very preterm baby, like INR of more than 2, APD more than 80 seconds, then I would transfuse. So maybe you can take 1.8 or 70 seconds in a less than 28 week PT of INR of 1.8 and APD of 70 seconds, and then transfuse if you're doing any procedures, or lumbar puncture or anything, then that might be all right.
Yeah, thank you, Dr. Deepak. Dr. Dheeraj Gupta.
Hello, good evening. Actually, my question is from Dr. Deepak regarding the dose of the vitamin K, whether it's a different as per prophylaxis and as per treatment. Like 1 milligram in prophylaxis is the same dose for treatment also.
Yes, in a term baby, Dheeraj, that's a good question. In a term baby, definitely yes, 0.5 to 1 mg is the dose what you would give it. But if in a preterm baby, suppose if you have already given the vitamin K, right, and then you suspect vitamin K deficiency, bleeding or something, then repeat dose. So repeat dose would be around 100 micrograms per kilo. The prophylaxis dose is around 400 mics per kilo. So in a term baby, remember 1 mg or 0.5 mg is a dose, same as prophylaxis. In a preterm baby, lesser, 100 micrograms per kilo for treatment.
Yeah. 1 second.
I think BNF mentions 400 micrograms per kilo, but I know most would go for a treatment would be like 100 micrograms per kilo.
Yeah, thank you, Dr. Deepak. Dr. Giridharan.
Sir.
Please go ahead with your question.
Sir, my question is also the same. I need the dose of vitamin K in classical HDN in a term and preterm babies, and how long we should give?
Yes, classical HDN, the dose would be 1 mg every 8 hours. Sorry, for term baby.
For term baby?
Yes.
Sir.
For preterm baby, if
for preterm, sir?
Yeah, for preterm, the prophylaxis is 400 micrograms per kilo, or most would give 0.5 to 1 mg. Follow what your unit protocol has it. But if you have documented that vitamin K has been given, the subsequent doses would be around 100 micrograms per kilo. So for
and how long we should give, sir, this one?
Sorry?
And how long we should give, sir?
You can repeat every 8 hours until the bleeding is corrected.
Okay. Okay.
But generally, 1 dose or 2 doses would be enough, So I think previously also I told, if you suspect vitamin K deficiency and the baby is bleeding, kindly also give your FFP also. Okay. And FFP will also contain your other coagulation factors. Yeah, so you don't have to buy time with vitamin K. So you are supplying the active factors like factor 2, 7, 9, and 10, which are vitamin K dependent factors. So you have to provide them. So you give FFP when you suspect when there is active bleeding. It's a good practice, especially in a classical HDN, and if the bleeding is severe, to give FFP also.
Okay, thank you.
I will answer your question. Yeah.
Yeah, I think, is there anyone else who would want to ask any question? I think we have covered it, most of the questions. And here we are coming towards the end of the session. Thank you very much for accepting the request to be a speaker. And it was wonderful session covering comprehensively the approach of neonatal bleeding and comprehensively covering everything about the platelet. Thank you, Dr. Archana. Thank you, Dr. Deepak. And thank you, Dr. Girija, for moderating the session so well. So I request all the participants to log in again tomorrow. We have anemia, polycythemia, neonatal thrombosis, and uses of blood products in neonatology. So join us back tomorrow, same time at 5 o'clock. So thank you very much. Have a great weekend and have a great evening. Thank you. Thank you all. Thank you all.
Thank you, Girisha, and thank you, Prashant.
Thank you, ma'am. Thank you, sir.
Bye, Deepak. Thanks.
Bye, Archana.
Thank you, Dr. Deepak. Thank you.